So thank you for having me. This is a remarkable turnout. I wasn't sure how many people I'd be coming to speak to, so I think you've done a fantastic job. Thanks to Jeff, Louise, and everyone for asking me and for rearranging so I could attend an important 6-year-old birthday party this morning. So I'm sorry I missed that. So it was a big title that Jeff gave me, and I only actually looked at it kind of 2 weeks ago while I was on holiday, and I thought, wow, I've got to cover that in 30 minutes. And so I thought, well, let's break it down and see if I can do it in 2 slides. So there were two questions: why science research makes me a better surgeon, and then how to deliver a great talk. Well, there's a bit of a judgment call. If I don't deliver a great talk, I've failed in my task. And secrets to sharing your science and your story. So let's see. So I'll do the first slide. And there you can see I've worked predominantly in 2 countries. I have done fellowships elsewhere, but predominantly in 2 countries. In South Africa, I looked at HIV exposure in pediatric surgery. I looked at HIV-specific surgical diseases, looked at how they relate to complications, predicted models of complications, both on an immunological basis and a clinical basis. And then for a variety of reasons, I moved to Australia, and those are my research interests. How to give a good talk, be clear with your message, tell the audience what you're going to tell the audience what you've told them. Don't have your slides too busy, talk, not read, keep to time. So that's a terrible talk. I'm not a researcher, although I didn't think I was. And I think you've heard this through a number of talks for a variety of reasons. I was never destined to be a pediatric surgeon. I was well into training as a cardiac surgeon. And as part of that, I had to do some time within a pediatric hospital doing general surgery. And I was like, oh God, and then I got put in burns. Who could think of anything worse as a potential cardiac surgeon doing burn surgery? And I met this man who's the love of my academic life. My wife knows this, so it's okay. And we have nothing in common with regards our clinical interests. He's a burn surgeon. He is a pediatric surgeon, and so I suppose we do have something. But much of his career has been dedicated to burns. But he taught me something. Maybe he didn't teach me. Maybe he awoken. Maybe instilled. I don't know how it happened. But the one thing that I can say about Heinz is, apart from he's a big man, his immense presence, but it was his curiosity and his passion that struck something within me. He's also fairly persistent, so if you didn't write the paper, he would really be at you for a few days. But it was the curiosity and the passion. And so it's going to be a theme that I'm going to try and take through this talk. And then it's how do you tell your story? How do you sell your science? We by nature, as a culture, as humans, are storytellers. We grow up listening to bedtime stories. We read our entertainment, our stories, our movies. We relate who we are to our friends and to people around us in stories. We talk about our childhood not as I was born here, I went to school here and I did this. You will talk about memories, you'll talk about stories, some of which will be partially true, some of which will be your own figments of imagination, but they're still stories. And so when coming to talking about your science, selling your career, it's about a story. That's all right. That's a new slide that I haven't seen in my talk, but I'll talk to it. So what you really want is a good teleconferencing system.
One that's not big.
You tell me when to continue. So it's really has formed part of who we are. And so if you remember that first slide, I think if you will permit me, I might tell them in a slightly different way of a flowchart, which is clear, it's concise, you can read the writing, but it's different. This is where I lived. This is where I grew up. This is where I trained. This is where I had many fantastic nights on the beach. I used to actually live just in the crux, just between Table Mountain and Lion's Head, which is just over there. And I used to enjoy surfing just over there with the great whites. I still have all my limbs. So it's okay. That's a story of where I began. But it had a darker side to it. And I can't even imagine that existence right now, because even if I go back to South Africa and I speak to colleagues, that existence has changed. But this was the reality. And so to try and tell you what it was like, it's a difficult process. But While the world was having concerts using Nelson Mandela's prison number, the reality was, as you saw, there was Thabo Mbeki, who was the current president of South Africa. There was a health minister named Nkosazana Zuma, who was both of which who were adamant HIV denialists at the time. And there was not a belief that HIV caused AIDS within South Africa, at least at a political level. Certainly not so at a medical level, but at a political level. And rapidly, AIDS became the single most pressing and devastating event that affected both Africa and certainly the country within which I was living. This is a world map that most of you knew or know, but this was the reality that we saw if you looked at that world map, not by landmass, but by HIV prevalence and AIDS infections. And there I was, stuck right in the epicenter of that bulge. Almost 2/3 of the population with HIV and AIDS were living in Africa at that time. And of those, at least 2 million were children. And one of South Africa's epidemic, because of the political situation and the refusal to provide mother-to-child transmission programs and highly antiretroviral therapy, was turning into an epidemic. It was affecting politicians that you saw. And if one looks at that, when will our nation and government comprehend that we have no greater calling at that time? And I'm talking about the early 2000s to address this emergency. So the negative impact factors that we had was that the concept that HIV and AIDS aren't linked. AIDS was a real stigma. It was more stigmatized than TB at the time. Traditional medicine was seen as a cure. There was a lack of funding, at least within South Africa. South Africa had an enormous growing debt, and this was our productive population. These are young, healthy males and females who should be working, but were ill. And this was, the cartoons appear as is a fantastic caricature of how he saw what was actually happening at that time. And this was my reality on a day-to-day basis working. Now, did I have an interest in HIV? None at all. Am I a natural immunologist? No, not even close. My interests were in cancer, but this was my day-to-day. And so this was my story at that time. And when we went to the literature, all we had was a lot about medical side of HIV treatment. We had much in the adult world, but we had nothing within how to treat children. And so there was a somewhat nihilistic view. We can't cure them, they're probably going to die. They're not going to heal. Everything we do is going to break down. And so we should adopt a more palliative approach for those children coming with either complications of their disease or in children who have normal pediatric surgical conditions, inguinal hernia, severe gastroesophageal reflux, tracheoesophageal fistulas, because we know that the likelihood of them healing is not going to happen. Where did this come from? There's certainly nothing in the literature. It was just dogma and or eminence-based medicine, but nothing that we could deal with. But we knew that surgical procedures where HIV patients were increasing at a dramatic rate. New surgical diseases were happening that we didn't even know what they were. We used to do esophagoscopies on patients and end up having CMV strictures. Until that point, there wasn't a single publication about CMV esophageal strictures. But yet, it continued. And so, under Heinz's tutelage, not because he knew anything about HIV, not because I knew anything about HIV, not because either of us had a particular clinical interest in HIV, but it was a need and it was our reality at the time. We just thought about, much like Gail did, with no funding. Actually, I lie, I did have some funding. We had some funding for a research assistant, but we chose just to collect the spectrum of cases that we had in detail. It was collecting details of patients around us. And in doing so, we were hoping to describe, just what we were seeing, because no one else was seeing this, or at least describing it. But for me, I wanted to take one step further. I was concerned about the lack of access, the lack of equity that we were able to offer. And so I wanted to see whether I could develop predictive models of complications, whether we could alter those with antiretroviral therapy, with improved nutrition, and look at ways for safely delivering surgical care to these patients. And so I landed up having an accidental PhD. I never intended to write a PhD. I knew that I was, by this stage, interested in research. But certainly, if one goes back now to that decade, my name will appear to the vast majority of pediatric surgical HIV. It was niche, but it was the reality that I had at that time. So that's the first story I have to tell you. That was half the graph that I showed you. But you've come back with me to a time which doesn't even exist anymore. And even if you went to work in South Africa right now, that would not be your reality. To understand the work that was done, you would need to see the story. And so that's telling part of it. Since then, HIV or surgery within HIV-positive patients has become a routine place. We're able to stratify them. We understand the CD4 counts and the viral loads that are likely to have impacts on those patients. We now recognize that HIV-negative, but children exposed to HIV-infected parents also have immune compromise and immune deficits, and those need to be treated prior to surgery. And with that, there has been an improvement in equitable access. But my story changed for a number of reasons. After spending some time doing a fellowship around the world, one of which was in Sydney, and going back to South Africa, I was recruited to come back to look at an academic deficit and a thoracic deficit that existed within Sydney. And so this is my happy place at the moment. There I am sailing with the 6-year-old birthday boy, and there's my little tyrant of a daughter who's walking off over there. But my reality was also this, is that I was working in a paradigm where we did thoracotomies on patients, and wow, did we do a good job. We thought we did a good job until you looked at what happened to them many years later. And the problem with children is that they change. Those of you who have kids will know that. They grow. What you have when they're this big is not what you have when they're that big. And what you do to them at that early age is going to have an effect on them later on. And so what you see here is a boy who's had a thoracotomy. He has a winged scapula on his dominant side, and therefore will have some degree of shoulder girdle weakness. He has a scoliosis that at that point didn't need corrective surgery, but went on to corrective surgery. And that was as a direct result of what we had done. I make no apologies for it. We needed to do it. It was a life-saving surgery for esophageal atresia at that time, but it was something that we wanted to look into. And so with an interest in minimally invasive surgery, what we saw was, could we do this operation? It was being done vaguely in the US, hadn't been done in Australia to date. And we wanted to see, using some of our equipment, and this is one of the challenges we had. We start off with equipment like that. That was the size of our patient. For those of you who aren't surgeons, who haven't done pediatric surgery, this is what an esophageal atresia looks like. Esophageal atresia is where you have a blind ending esophagus on the top, and then you have the distal esophagus, which is attached to the trachea and then feeds down into the stomach. And for anatomical reasons, because the patient's not standing up when I operate and they're lying down on their side, I've put that picture on your side so you can understand some of the anatomy as you see it. And so what you see there is the distal esophagus entering into the trachea. You see the vagal nerve over there. That's the lung which is compressed. You now see the upper pouch being pushed down. And using 3mm instruments, this is now the anastomosis that we've done. Since then, with philanthropic funding, on telling my story, we now have $2.5 million and 5 theaters that look like that, which are really dedicated towards endoscopic surgery. And this is what we do endoscopically or minimally invasively in patients with thoracic surgical diseases, with thoracotomies and or being an unusual approach and only for specific indications. And so what I'm proud to say is part of trying to do things a little bit better, we've gone from this, the same child now, that's what their scars look like. There's one over there, it's a 3mm scar here, 3mm scar here, and a 3mm scar there. But I said to you, one of the things that I realized is that our patients are changing, and they continue to change. And all of a sudden, while we were very proud of ourselves as a pediatric surgical group, we could pat ourselves on the shoulder and say, yes, with esophageal atresia, we have a 95% plus survival. And it's only really those with significant other comorbidities that are dying. We've done a good job. But no one asked what happens to those patients. They become adults. They become people who might be in this audience, in fact. And so one of the things that we did was start talking amongst ourselves. And it was this girl over here who presented. So I was sitting in a thoracic chest meeting, or what we call the chest meeting, which is a thoracic x-ray meeting. And this girl presented, and she had an esophageal atresia repair done. She looked wonderful. She was eating. She was drinking. She was discharged. And represented like this. Now, for those of you not familiar, this is overt bronchiectasis and complete destruction of her left lower lobe. And what had happened over years is she had had recurrent respiratory tract infections. and in fact had a recurrent fistula that no one had picked up because it was really something that she had grown up with. She understood it. She knew how to live with it. And so through that, Dominic Fitzgerald, a pulmonologist who was following up congenital diaphragmatic hernias, probably seeing 8 to 10 new patients per year, which I approached him and said, well, could we work together and start expanding the nature of that clinic? And so from doing just 2 of us seeing patients together once per 4 weeks, we now have a clinic that runs 3 times per 4 weeks. And it's staffed, this SLC is the surgical lung clinic, and I'm very proud to say that we have general medicine, we have an ENT surgeon. She's currently on maternity leave, but we're hoping that she's going to come back soon. We have a gastroenterologist, speech therapist, nursing, dietetic surgery, and respiratory medicine. And so when these patients come and see us, this is the team environment that they're exposed to, so that we can look at them in a different way. I have to tell you, as a surgeon, I'm terrible at long-term follow-up. But with the team around me, I think we do an okay job. But what's more important is that we record what we do as we go along. And so integration of our clinical practice together with our research practice has led to a number of improvements. With growth in nutrition, we recognize many of these children were failing to thrive in the first 6 months, and they needed extra nutrition moving forward. That some of the concerns related to neurodevelopmental outcomes in these patients were probably not necessarily founded. It brings me to the last chapter of this story. I don't know where my next chapters are going to be because it's already been a fairly diverse course through my career. But this is one that I think has stuck with me and one that will probably stick. And again, there's a story behind it. There is always a story. I was 10. I lost a good friend to Ewing sarcoma. That's a rare bone cancer that I'd never heard of until I actually started in a career of pediatric surgery. So that always stuck with me, and I thought, well, that'll be easy. I'll just test every single compound known to man, even grass, even insects. We put them under the microscope, mix them with cancer cells, and we should find a cure by the time I'm 21. Life will be good. But that's not the reality. But it still has always been a clinical interest of mine. One of the things that frustrates me with cancer is that we have a pretty much cutting-edge 1980s approach to it within pediatric oncology. We throw a bucket of treatment. We have done well in that we tailor the treatment, a little bit more chemotherapy for one, a little bit less for the other, a little bit more surgery for one, a little bit less for the other, and a little bit more radiotherapy for one, a little bit less for the other. And we've been very effective in doing this through international cooperative studies, which we are part of in Australia. And we've managed to improve the survival of childhood cancer. But the reality, however, is that there are now a significant group of patients who are more likely to die of their disease, of their treatment, than they are of their cancer. And so if one looks at Wilms tumor, which is a renal tumor of childhood, we can now cure well over 90% of those patients with these 3 modalities. Yet after 5 years post-treatment, they are more likely to die of one of these treatments than they are of that Wilms tumor. And that for me is a problem. Within the last decade, there have been some important changes in ALL. That's leukemia, acute lymphoblastic leukemia. It's one of the most common childhood cancers. Now, I know nothing about leukemia. I'm a surgeon. I'm a surgical oncologist, and so everything I deal with is gross, obviously solid tumors. This is a liquid cancer. It's a fascinating liquid cancer. It in itself has the most wonderful story, and I'd encourage you all to read The Emperor of All Maladies by Siddhartha Mukherjee, where he goes and he describes Sidney Farber down in Boston, Mass, who was a pathologist who was just throwing different agents at these. He threw folate at it, and that made the cancer get a lot worse in the kids. So he threw an antifolic agent at it, and that did quite well. And there's methotrexate for you. So it has a fascinating story. So it was through this that I started looking at it. And they've done a wonderful thing. What they do is they look at the patient and they say, yes, you have leukemia. They look at the age and they say, yeah, you have some high risk factors. But why not? Let's give you some treatment and let's see what happens to those cancer cells. If after an induction course of treatment, you've lost all your cancer cells, you are likely to do pretty well. It makes sense, doesn't it? But if you still have residual cancer, then you've got some minimal residual disease or resistant clones of cancer that are likely to re-emerge because they've already failed with the treatment that you've given. And this has completely revolutionized the way in which leukemia has changed. But the thing with leukemia, and don't let the oncology team know this, it's actually a really easy disease because you know where the MRD hides, the minimal residual disease hides. It hides in the bone marrow. And so it's easy to find it. There's also a restricted number of translocations that occur. And so if you just run a very sensitive PCR assay on the bone marrow, the chances of finding MRD are quite good. That's not true for solid cancers. We really only have surgical biopsies. Now, I'm a surgeon trying to put myself out of business, which is not a good business model for the record. Well, the issue is it's invasive. It's surgery. It has complications. And that's when we have the initial tumor. But what happens after they've received cancer, their chemotherapy, they've had surgery, we have no tumor to follow, and they've had radiotherapy. Yes, we have PET scans, but PET scans still have a 1 centimeter threshold in order to pick up that cancer. So we have about 10 billion cells by the time we have a 1 centimeter tumor. That's no good. That's not the time to recognize that you have resistant disease. And so with the revolution of next generation sequencing and improved ability for PCR techniques such as ddPCR, what we've been able to do is, through much of our obstetric colleagues, in fact, who have developed looking at fetal DNA, or what we call NIPT within the mother's blood, we've managed to adapt some of those same techniques to cancer. And so the concept that I had or thought through was, well, if I can still detect evidence of that cancer within the patient's blood. I don't know where the cancer is, but I know that it must still be there. And hence, our concept of a liquid biopsy. So what's a liquid biopsy? That's a cool term. I like it. I didn't develop it, but it's what got me interested. So if we have tumors in and around the body, what will happen is they will break down part of their DNA and RNA, and that will be secreted into the blood. The fragments have been broken down significantly, so it doesn't necessarily resemble the DNA as it was when it was in that cancer cell. But many of those fragments will still represent key mutations and key translocations that were present. We also know that there are now circulating tumor cells. They are incredibly rare. There's probably only 1 to 5 of them per ml of blood. And so finding them is a challenge. But if we understand them, we know those must be the precursors to metastases because they're living in a hostile environment. They've broken up from the tumor. They're surviving in one of the most immune active environments possible. We can even look at other body fluids, and one of my collaborators in the lab is looking at CSF, looking at how we can use CSF MRD to monitor brain tumors. That's not my interest, but the point is we can do this in any body fluid. And so by isolating either DNA, RNA we've had less success, but certainly DNA and circulating tumor cells, we were able to find those same translocations, those same point mutations, and those same abnormalities that we might otherwise find on a tissue biopsy. Even better, we can repeat this at multiple time points. So at the time of diagnosis, you may even be able to make a clinical diagnosis with just a blood test. So for example, if a patient has a big renal tumor, some of which would do better with upfront chemotherapy, some would do better with upfront resection, and not wanting to biopsy it for fear of spill, a blood test may be able to provide us that option. To look at whether after surgery we still have persistent disease and whether chemotherapy may or may not need it, and I'll show you a colorectal sketch with that later. My area of interest in looking at minimal residual disease. But what it also enables us to do is know what the genetic makeup of that tumor was from the tissue biopsy and the original liquid biopsies. And then if we start seeing an emergence of a new clone or new disease on the liquid biopsies, because we can interval, we can biopsy at multiple time points, we can then understand there's been a mutation and change. And certainly within the adult world, that has been used frequently. BRAF inhibitors are a source of treatment for melanoma. And we know that the BRAF V600E mutation proves resistant to that. You can pick that up on a liquid biopsy. And certainly that is now in clinical practice. We can also look at following up patients by taking their bloods at serial samples and detect the presence of cancer before it becomes radiologically evident. There are, however, a number of challenges for us. The diseases within childhood are quite different. We don't have point mutations as the adults. We have structural variants or fusions, and this has made life a lot more challenging. But what we hope to do is something like this. If one takes a look at colorectal disease in adulthood, if we take stage 2 disease, there's only about 10% of patients who will actually have metastatic disease and require chemotherapy. But yet, all patients will get chemotherapy. With stage 3 disease, about half of them will have it. But again, all will get chemotherapy. With the liquid biopsy, if we have to resect that cancer and 3 weeks later, we then go and do a tumor-specific blood test looking for evidence of disease, and there is none, we can be reasonably reassured that there is no presence of cancer within that body, and those patients can be spared. And so just the 10%. In adults, that may not be a big deal giving everyone chemotherapy. But in childhood, you have to remember my story. They are more likely to die in many cases as a result of their treatment than of their original disease. And so for that reason, our work is situated mostly around looking at circulating tumor DNA, circulating tumor cells and exosomes. We take biopsies at induction, surgery, post, and follow-up. And to date, we've managed to develop ctDNA assays for both NMIC, which is one of the major drivers in neuroblastoma. We've developed patient-specific assays, which is a very bespoke approach of sequencing the original tumor, setting up a primer for that patient, and following their course of treatment. And then looking at specific drivers in hepatoblastoma, which are actually a lot more sensitive than the biochemical assays that we have over there. We're also looking at osteosarcoma circulating tumor cells. But there's a big group that does this, and I will address that in my closing remarks now. So Jeff gave me a question. Well, he gave me two actually. Why science or research makes me a better surgeon? I don't know if it does. I must be honest. It potentially makes me a worse clinical surgeon because I'm up late writing grants. I'm often in the lab. I'm trying to rush between the two. I'm trying to be a good researcher, a good surgeon, and a good family person. And I'm not sure that I get that balance right. I actually know I don't. But what it does do is it teaches me to ask questions. It teaches me to look beyond. It teaches me not just to see the old man or the woman. I'm not sure which one you saw first, but they're two. It shows me not just to see the skeletons, or not just the single idol in the middle, but the two that might be opposing each other over there. It teaches me to look further. It teaches me to have interests. It teaches me to be inquisitive. But more importantly, I realize it teaches me that I can't do this alone. I can't do it without my family. I can't do it without a great group of scientists that you saw before there. I can't do it with a group of biomedical engineers who are doing a lot of the 3D printing. It's about creating that team. It's not different with surgery. Having an important surgical lung clinic team, they're a lot better at long-term follow-up clinic surgery, long-term follow-up than I will ever be. But being there at the center and coordinating that is important. So how to deliver a great talk? I don't know whether I have. You be the judge of that. I think that what you have to have is curiosity. You have to have passion, and allow that to filter through to the audience. You need to take them to the place that drove that curiosity and drove that passion. And both our previous speakers have done that. So even if this talk never achieved that, at least I can say thank you to my previous speakers for having achieved exactly that. They took you to a place so you understood what it was that drove them to achieve what they wanted to do. I'd like to thank you again for your attention. I'm happy to take any questions.